All right, welcome in. This is the knee post-operative. This is a part one of two. We're trying to make these shorter little lectures here to not be so daunting, but there are going to be two parts. This one is going to be looking at things like cartilage injuries and so on and so forth, and the other one's going to be looking more meniscal, ligamentous injuries. So without further ado, let's get into it. So the objectives of the knee section here is to review common postoperative diagnoses of the knee, as well as review the current literature in the management and progression of PT interventions, to take into consideration certain postoperative precautions, including range of motion, weight-bearing status, and return to play guidelines, and elicit critical thinking when working with these patients. So surgical interventions of the knee, an overview, we have all these different types of surgeries that are common in the knee. The knee is likely the most common area that is surgically fixed with orthopedic surgery. And so we have to be able to understand all of these different surgeries and what they mean. Now, we're going to go over the most common types of knee surgeries here. So don't feel like this is too daunting of a task, but things with the meniscus and the cartilage and the ligaments are going to be the big things we need to focus on. So how do we make sense of all this? We try to break it down into different tissue types, and you can see them listed here. If we do that, then we know how to load them, to progress them, and as time goes on, your clinical experience increases, you'll feel more comfortable with this. So considerations for postoperative knees, well, obviously we want to take into account weight-bearing status, range of motion limitations, return to sport timeline considerations. We definitely want to control effusion. There's something called arthrogenic muscle inhibition, which we'll get into. We want to make sure that they maintain a mobile patellofemoral joint. We want to get the quads activated very quickly, and then prioritizing extension over flexion in the first 2 weeks postoperatively in nearly all cases of knee surgery is going to be important. So again, reviewing the anatomy, you can see this sagittal plane cross-section view of the knee anatomy. And what I want you to look at here is arthroscopic versus open procedures. If here's what it looks like to have an arthroscopic procedure. You can see the tools inserted into the knee, kind of in the anterior interval on either side of the patellar tendon there. And then an open procedure looks something like this, where there's a large incision down the front of the knee, exposing the patella and then getting into the knee joint that way. Postoperatively, an arthroscopic portals look like this. Open incision looks like this once the integumentary system has been repaired here. So what is arthrogenic muscle inhibition? You can see the picture on the right, how this is a large swollen knee. This is not a DVT. This is just normal postoperative swelling. So AMI refers to impairment caused by an ongoing reflex inhibition of the musculature around a joint. It's a protective mechanism. It's a reflex inhibition that increases swelling to splint the joint. So it creates all this effusion or swelling within the joint so that you can't move the knee. This is a protective, adaptive mechanism. But here's the thing, with as little as 20-30 milliliters or 1 ounce of fluid, there have been saline studies that show that produces quadriceps activation decrease. So one of the big things, we try to get rid of the effusion relatively quickly, even though we encourage inflammation postoperatively because we think it aids in tissue healing. It will also decrease the ability for the quads to function. So there's a fine game that we play. So again, AMI treatment strategies, you have a joint injury, may lead to immobilization of the joint, which then leads to muscle atrophy, which then leads to muscle weakness. And with that, you might have another injury. So we try to manage this phenomenon the best that we can. So this is something you can look up more on your own as well. AMI, arthrogenic muscle inhibition. What is the anterior interval? Where this is the area in the front of the knee that is comprised of the patellofemoral complex, the bursa, the fat pad, and the peritoneum, and often becomes fibrotic following arthroscopic portal placement. And so that's why it's very crucial to maintain anterior interval mobilization, patellofemoral, and fat pad mobilization postoperatively. You can see this is a picture of a knee postoperatively here. The incisions are healed. If we look at the anterior interval of the knee, arthroscopic tool goes in. You can see there's the kneecap, there's the anterior interval or fat pad. You have your arthroscopic incisions. You have your open incision or graft site area. You have other incisions that are used to help pass grafts if this is an ACL. And so we got to make sure that the kneecap stays mobile. So what we do here is we try to understand the anatomy of the patellofemoral complex. So we're mobilizing the patellar and quadriceps tendon. We're mobilizing up, down, left, right. We're trying to increase gliding of the surfaces here. So as you can see by some of these pictures, this is what we're trying to encourage. So in most cases, when we think about range of motion following knee surgery, the priority should be placed on improving knee extension first and knee flexion second. There are exceptions, but this is a general rule of thumb. And why do we care about extension first? Well, post-op effusion limits mobility, and the position of comfort is around 10 to 20 degrees of flexion, and a patient can get stiff in this position. Increased edema and effusion can create pain and AMI, which inhibits quads. Decreased quad strength equals decreased stance. And you can see how there's a cascade of poor events that occur here. Need to get extension back quickly. So Shelburne et al. 2012 looked at 780 ACL reconstruction patients for 10 years, and basically what they noted is that the amount of osteoarthritis increased significantly if even 5 degrees of range of motion to extension was lost on the surgical side. So we need to get back extension so that we can have better joint loading during movement. So let's talk about chondral pathologies, and some of these on here I've actually taken out because they are too advanced, I think, for this class. We're going to go briefly over chondroplasty, microfracture, and then knee arthroplasty. So just a brief view here on cartilage anatomy and considerations. So on the very left side of the screen you see healthy cartilage, and then you have an injury, then that increases the inflammatory response. The cartilage over time starts to break down, and then later stages OA we can see some of that superficial and middle zone of cartilage has now fully worn away, and we are exposing now subchondral bone in some cases. And so when we have cartilage injury in the knee, it looks something like this. So you can see how that superficial layer of cartilage is now worn down, and we have defect in the cartilage down all the way to the subchondral bone. And when that engages during range of motion or loading, it hurts. So what's a chondroplasty? Well, chondroplasty is something that surgical procedure to smooth out the degenerative cartilage and trims unstable cartilage flaps to stabilize and treat this. Basically, post-operative precautions here is they're going to be weight bearing is tolerated, but we restrict resisted knee extension exercises if there's patellar or trochlear involvement, because that increases compressive forces. Rehab timeline is anywhere from 1 to 2 months, but for athletes maybe 3 to 4 because they're getting back to higher level activity. Another type of cartilage treatment is something called a microfracture. You may have heard of this before. This was invented by Richard Stedman. It is a common procedure to treat patients with full thickness damage to articular cartilage that goes all the way down to the bone. And basically what happens is they create little burr holes in the cartilage defect to elicit bleeding. And what this bleeding does is creates a superclot, as they call it. And here's a better picture of that. So they use these burrs, they poke holes literally into the bone to elicit bleeding. This, I guess this fibrin clot, this blood clot forms in the cartilage defect and then regrows basically new cartilage. Now this is not hyaline cartilage, this is fibrin cartilage, and so it's not as good as your native cartilage. So here are some postoperative considerations for microfracture, both chondral and trochlear or patellar. So chondral just meaning on the condyles of the femur, and trochlear meaning obviously either the trochlear groove or the patellar, posterior patellar surface. So both of these are going to be partial weight bearing for quite some time, and then with the patellar or trochlear one, we're going to have a progressive increase of knee flexion over time so we don't increase compartmental pressure there. What about knee arthroplasty? Well, there's two types of knee arthroplasty, a partial knee replacement and a total knee replacement. But yes, total knee replacement is characterized by a disease of cartilage of the whole entire knee joint, the tibiofemoral joint. So if you look at the box on the right, common risk factors of OA of the knee, age greater than 50, obesity, being female, especially for knee OA, family history, history of immobilization, injury to the joint, prolonged occupational or sports stress. And so what's the prevalence? Well, 13% of women and 10% of men age 60 and older have symptomatic knee osteoarthritis. the proportions of people affected with symptomatic knee OA is likely to be increased due to aging population and with our high rates of obesity or overweight in the general population. So during a 1-year period, 25% of people over 55 may demonstrate persistent episodes of knee pain. This is why orthopedics and PT is so important, because we can really help these people. So this is got some schematics on the right of what it might look like to have a normal knee with good joint line and joint space, as well as advanced osteoarthritis, where we're seeing a decrease in joint space here, meaning the meniscus is wearing away. There's no padding in there. And so this is before and after a knee replacement. We have some different types of indications for who needs an total knee replacement, and this is a picture of an x-ray rather of one of my former patients, and then this is a picture I found online that kind of demonstrates what it looks like on the outside. But you have this medial compartment collapse. You can see there's absolutely no joint space. This person is an varus deformity, and these are the things that might be recommended for surgery in these cases. This is teeing it up in a nice home run for a surgeon. Oh yeah, you need a knee replacement. But really it depends on the person's function and pain. You'd be surprised how many people have knees like this that actually get around pretty well. So what does it look like? A knee replacement, knee arthroplasty looks like this. A partial is usually just going to fix one compartment of the knee, usually the medial compartment. And then we have the total knee replacement, which has a patellar component here. And so that's what we have there. What's the procedure? Well, I'd like you guys to, one, look up this link and to understand the procedure, and then please watch that YouTube video. Now, it is graphic, but it is a very good visual for you to understand what these patients go through. What about post-operative guidelines? They're going to be weight bearing as tolerated. It's usually dictated by the patient's pain, but we're trying to get them up and moving quickly. Progress from partial to weight bearing is tolerated to full weight bearing. They'll typically use a front wheel walker following surgery. Range of motion, we're going to start moving them as soon as possible. Extension and flexion. Focusing on extension first, but flexion too. Goal is 90 degrees of range of motion within 4 weeks and 120 degrees in 6 weeks. Swelling and pain are major limiting factors, and we need to address these immediately. If a knee gets stiff, we consider stiffness at about 6 weeks post-op. If they're lacking 15 degrees of extension and they can't get really more than 75 degrees of knee flexion, they have a very stiff knee, they might have to undergo something called a manipulation under anesthesia, which is basically they put you under anesthesia and then forcefully flex and extend your knee to break up any scar tissue that has formed around the knee joint. Then you're doing PT for 1 to 2 hours a day, 5 days a week for a minimum of 2 weeks to maintain that range of motion. So that's not something that we want our patients to go through. So we try to get them better otherwise. What about meniscal pathologies? So we're looking at meniscectomy, meniscal repair, and we'll quickly mention a meniscal transplant. So meniscus anatomy, of course, we have these two C-shaped menisci. You have your medial meniscus and your lateral meniscus. And one thing I want to point out here, though, is this area called the red, white, and white zone of a cross-sectional area. This area in here, this white zone, has poor vascularity. It does not heal well. So this tissue is usually removed, and it's something like a meniscectomy, whereas the tissue more lateral to the meniscus is going to have a higher blood supply. So we might think that these have a better propensity to heal with a meniscus repair or a suturing of the meniscus. So what's the mechanism of injury for meniscus pathologies? Usually a rotational force under axial load and a flexed knee. There's several different types of meniscus injuries here. You can look at those there. A lot of these will constitute large repairs, as you can see how much damage there is. So it's a very common type of injury. So surgical intervention depends on the size and location of tear. A meniscectomy, you might just go in and remove the meniscus or a portion of it for non-repairable tears, usually in the white zone. A meniscus repair is salvageable tissue, preferred in the red zone. And a meniscus transplant may have a history of complete meniscectomy or severe tears in younger individuals who are not obese. Those are the individuals usually maybe candidates. Surgical intervention here with the meniscus, they're usually responsible for 750,000 arthroscopies per year in the United States, the most common orthopedic surgery. A meniscectomy looks like this. They go in, you can see this flap of tissue. They go in and they trim that up so that this flap doesn't get caught and create pinching and pain. A meniscal repair looks like this. They go in and suture the tear And then finally, a meniscal transplant is more of an open surgery. They actually get a donor and they insert this into the knee and fixate it to. It's a very complex surgery, and not many surgeons do it, but that is a newer technique they're doing. So what about a meniscectomy? Well, in the mid-1900s, the meniscus was just removed. They didn't even think that this really did anything. They think it was just, hey, let's just cut this out, and it's causing pain, so let's just get rid of it. So this is still a very common procedure, partial meniscectomy. They'll remove some of the meniscus, but not the entirety of it. And we want this to protect the articular cartilage, so we need to keep as much meniscus in our knee as we can. Post-op precautions are going to be weight bearing as tolerated, no deep knee flexion, rehab timeline somewhere between 4 and 8 weeks. A meniscus repair is going to be very similar in the sense that we're working on the meniscus, but we're going to be suturing it down. So you can see the meniscus tear here. We're going to be placing sutures in the meniscus to repair it because we think that this area, again, here's that cross section of the meniscus, has better vascularity and blood flow, so this will heal. The issue, though, is that we're going to be non-weight bearing on that knee now for 4 to 6 weeks because we don't want to increase pressure through the meniscus through axial loading. No knee flexion greater than 90 degrees for 4 weeks, and rehab timeline is somewhere, and this is very fast, 3 to 4 months. I would say now it is transitioned to being more of a 5 to 8, 9 month surgery in most cases. So what are other considerations post-operatively? Well, with a medial meniscus repair, you want to avoid hamstrings activation, and the reason being is because there are menisco ligaments here that attach to the semimembranosus, so we're getting a lot of hamstring activation, especially in a root repair. We might want to limit hamstring activation. Anterior horn injuries, we want to avoid knee hyperextension due to the kinematics of the knee. Posterior horn injuries, want to avoid deep knee flexion. So with that, I want to say thank you. I appreciate your time. And the next lesson is going to be going over ligamentous type injuries.